Hello. Today I'll discuss about certain disorders related to excess amount of bilirubin in the body, that is hyperbilirubinemia. Now see, as we know that whenever the bilirubin, serum bilirubin level crosses 2 milligram per deciliter, then we are having chances of jaundice, and that is identified basically as a clinical manifestation. We know that there is scleral ectasis because in the sclera we have elastin, higher contents of elastin, and elastin has a higher affinity for bilirubin. Okay, now see, we know that jaundice can be three types: prehepatic, hepatic, and post-hepatic. In the prehepatic, we know that there are chances of hemolysis, or it can be that the erythropoiesis rate has increased, RBC production has increased, so automatically RBC destruction rate will also increase. It can be physiological, it can be pathological, but that should be related to, you remember, hemolytic anemia. In cases of hemolytic anemia, there are chances of jaundice. Okay, then in the hepatic region there can be any type of hepatitis, the inflammation of the hepatocytes. Hepatitis virus can be infected like A, B, C, D, E. Then we have Epstein-Barr virus, then we have the cytomegalovirus, then we also have something that is tuberculosis. And also remember other factors, we have the vinyl chloride, which are environmental pollutant or substances which slowly get accumulated, and this can lead to jaundice. Then we also have alcoholism. We know that alcohol, this is very toxic, and when it's entering into our body in excess, then we can have this type of symptoms. In the post-hepatic, remember, there is obstruction in the biliary pathway, so automatically there is some, it can be some gallstones and all, they can obstruct the canaliculi. There can also be obstruction at the level of the common bile duct and all, so automatically there this cholestasis will actually happen, and there will be formation of stones. Okay, so that the pain that we actually get on the right upper quadrant of the abdominal region, that is actually a symptom that the patient will complain of. Then talking about something that is called as the Crigler-Najjar syndrome. Now Crigler-Najjar syndrome, that is very rare. First of all, there are two types. One is the type 1 Crigler-Najjar and one is the type 2. Now see, in type 1 what happens, it specifically happens in the neonates, and there the bilirubin, serum bilirubin level crosses 20 milligram per deciliter, and that can lead to kernicterus, in which there is basically accumulation of bilirubin in the brain, which will cause neuronal problems. Now see, talking about what actually happens there, we know there is an enzyme that is called as uridine diphosphate glucuronosyl transferase, that is UDPG, okay, T transferase, and there the gene mutation will happen for which the enzyme will not be produced in type 1. So automatically those children, are those neonates rather, they are having higher chances of suffering hemolysis and automatically death. The level of, there will be higher jaundice, means elevated levels of jaundice, and there will be death. Then there is another thing, that is Crigler-Najjar type 2, which is actually, it starts from the childhood only, but it can continue. It is actually more common than the type 1. Type 1 is very rare, whereas the type 2, it's common, but it is seen even in the adulthood stages also, because the enzyme, of course there is gene mutation, but there is reduced action of the enzyme, because that enzyme might be, it is not properly synthesized, so that there can be problem with that enzyme. Okay, but the enzyme is secreted. It's not that like in type 1 there was no enzyme, but in this case there is some little amount of enzyme. Remember, so for that we actually administered phenobarbital, and this drug actually induces UDPGT, so that it can actually, and also it will reduce the levels of serum bilirubin, so that what will happen, the enzyme will act properly, because we need to actually transfer this. There will be glucosyl transferase enzymes, of course, so there will be conjugation. Okay, you need to conjugate bilirubin. Bilirubin has two forms, we know, one is the unconjugated and one is the conjugated. So for conjugation we need this enzyme. So that was Crigler-Najjar, and another thing is there, that is the Gilbert syndrome, which is more common, and in this case we see that the levels of unconjugated bilirubin, because the same thing, it is similar to Crigler-Najjar syndrome, but this happens eventually. There are other causes of this Gilbert syndrome, but in this Gilbert syndrome, remember that the serum bilirubin level is above 6 milligram, or it can be up to 6 milligram per deciliter, times it can be slightly above the value also, above that range also, and there also there is reduced action of that UDPGT enzyme. Okay, that enzyme is, of course, it is actually showing reduced action. So that was the difference between Crigler-Najjar and that Gilbert syndrome. We know another thing that you should remember, that is the Dubin-Johnson syndrome. Now what is Dubin-Johnson syndrome? When the conjugated bilirubin is coming out from the hepatic tissue, that is hepatocytes, hepatic sinusoids, bile canaliculi, and it's eventually draining into the bile channel, that is basically the common bile duct. At that point of time, there is particular transport protein, that is multi-drug resistant protein 2. So if there is any chance mutation in its gene, or there is some problem in the synthesis of that particular protein, then that condition is called as the Dubin-Johnson syndrome. Again, remember that the form of the conjugated bile, bilirubin, that is produced, that is also recycled into the hepatocytes, and there are certain transporters like the organic anion transport protein, OATP 1B1 and 1B3. So these proteins basically recycle them. So if there is any problem with those transporters, then we get to see what we see, that is basically the Rotar's disease. Okay, so then we have seen in particularly under jaundice, we have seen the Crigler-Najjar syndrome, we have seen the Gilbert syndrome, we have looked into the Dubin-Johnson syndrome, and also the Rotar's disease. Okay, so that was a very rough discussion. Thank you.